Hi, this is Callum. In this video, we're going to talk about breast histology. So there are two main types of breast specimen. You will get breast resection specimens and biopsies. And breast resection specimens are either mastectomy specimens or they are wide local excisions, which are taken as part of breast conserving surgery, where they just cut out the lesion itself with a bit of surrounding breast tissue. You also get diagnostic biopsies. These form a large part of the workload in breast pathology, and these can be taken as a result of symptomatic breast disease, which is usually in the form of a breast mass, or as part of the breast screening program. The breast screening program has been around for many years, and primarily what happens is, as part of mammography, which is a form of X-ray which you get as part of that screening program, this will pick up calcification. And calcification is small aggregates of calcium which develop often in the context of malignancy. So the patient presents to the breast screening program, and mammography, the X-rays pick up calcifications. Those particular areas are biopsied. We have a look at those biopsies to tell whether or not it's malignant. And then if it is, this patient may go on to have a completion mastectomy or a wide local excision. So this was part of a mastectomy. This is actually a normal section taken from the specimen, or normalish. So a quick review of the structure of the breast. Each breast has roughly, there's natural variation, but around 20 lobes. Each lobe is comprised of multiple lobules, which are the glandular units. The glandular units feed into ductules, which feed into larger ducts, which in turn converge upon lactiferous ducts, which open onto the surface of the nipple. That architecture is you'll find in textbooks, but in practice, both macroscopically when you're dealing with specimens and microscopically when we look here, that structure is not really apparent. And this, what we're seeing here, is what we usually see. So it's not easy to see where one lobe starts and another lobe stops. It's not easy to tell where the collagenous bands that divide lobes are. But what we see, and what we can see at low power here, is lots of pink stuff. Now that's the dense collagenous connective tissue, which on macroscopically, when you're dealing with a specimen, would be cream-colored, firm, rubbery material. And also this white stuff, and this is adipose tissue. Adipose tissue in the breast is the same as adipose tissue anywhere else, which is to say it's made up of adipocytes, which are balloon-like cells with small nuclei out to the periphery, and clear cytoplasm, which in life would have been full of fat, but in histology, because we use alcohol which dissolves out the fat in the processing, are just empty spaces. So these big empty spaces, the white stuff we can see is fat, and the pink stuff is collagenous tissue. And mainly arranged within the collagenous tissue, but also out in the fat, are the epithelial elements of the breast, and there are two. So there are these things, which are the ducts, which are the open spaces lined by epithelium, and the round structures, which are the glands, which form lobules. So it sort of has a tree-like architecture within the breast, a bit like the lung, which we'll come to in a video shortly. The tree-like architecture is formed of glands or lobules, which drain into ducts or ductules, which drain into, in turn, bigger ducts. So all of these lobules will drain into ductules and ducts, which will again feed probably this duct here, which will continue on its path and eventually end up in a lactiferous duct. So it sort of has a tree-like architecture. And if we zoom in for a little bit, you can see that. So if we look at this lobule here, we can see the small glands radially rearranged in what we call an acinar arrangement. Acini, I think, means berry. So if you imagine like a raspberry, raspberries formed by all these small round structures which are clumped together to make the whole raspberry, and just like these small glands aggregated together to form a whole lobule. That's an acinar arrangement. So all these small glands are discharging in their secretion into the small ductule, which is coming this way. We lose it in this section, but it might open into this larger duct. And all of these lobules will have similar ducts, but we can't see them clearly on this plane of section. So we're getting a better, closer look. Here's the fat that I was talking about, and this is the dense collagenous tissue. But there's actually another type of collagenous tissue that we couldn't see so well in lower power. But this is the dense pink collagenous tissue, which is just collagen and fibroblasts mainly. And that's called the interlobular stroma because it's between the lobules, interlobular. Whereas the intralobular stroma is within the lobules and it's between the small glandular units, and it's much looser, paler, more vascular. So intralobular and interlobular. Okay, if we look at higher power, here, this is probably quite a good one to. So we'll do both the glands within the lobule and the ductules or the ducts have the same structure, and that's actually similar to what we saw in the prostate in that it's a bilayered structure. So we can see here, maybe we'll zoom in just a little bit further. We've got two layers here, and you can see this quite clearly. Sometimes it's not so obvious. This is the lumen of the gland here, and we've got a single layer of low columnar or cuboidal epithelium, which, if this was a lactating breast, would be secreting, but this is a non-lactating breast, so it's dormant. So these are the round nuclei, and they've got a little bit of cytoplasm, apically orientated. Apically orientated just means towards the luminal side, and the nuclei are towards the basement membrane side. But beneath that single layer of epithelium, we've got another layer, so it's bilayered, and that's these cells which have abundant clear cytoplasm. And that's a nucleus. This is the cytoplasm of that cell. If we follow that round, there's another nucleus with lots of abundant pale cytoplasm, another nucleus. And these are the myoepithelial cells which surround the epithelium on the outside. So two layers, myoepithelial and myoepithelial because they have contractile ability, and the epithelial inner layer. So that's the bilayer. And let's see if we can find that. So all of these glands have the same structure, the bilayered structure under normal conditions. Let's see if we can prove that in the duct as well. Yeah, so this is nice, and you don't always see this so clearly, but here we've got epithelium. This is the lumen of the duct. Epithelium, so cuboidal or low columnar epithelium, and then underlying that, nucleus, clear cytoplasm, nucleus, clear cytoplasm of the myoepithelial cells. So it's bilayered. Okay, so that's pretty much all there is to say about the breast, to be honest. We've got this dense collagenous stroma, the lobules with their acinar structure, architecture, the ducts, adipose. That's pretty much it. So, like the prostate, within breast pathology, there is benign pathology within breast, but the main question you're usually trying to answer is this malignant? And like in many areas, there are certain hallmarks of malignancy that you can identify within the cells that you look out for to decide whether they're malignant or not. And like in the prostate, the architecture is also useful. So at low power here, we can see this organoid architecture of glands, round glandular sort of aggregates of the lobules and the ducts. And that's an organoid architecture that's organized, whereas if it was malignant, there would just be glands infiltrating every which way. and that would make you suspicious that you were dealing with malignancy, or invasive malignancy. And then when we look in higher power, let's look at the duct. In higher power, we can see these are all pretty much the same size, roughly the same size and shape, all of these cells, and they've got a nice duct architecture, bilayered architecture. Now, there are hallmarks of malignancy which are common to many tissue types when you're deciding whether something is malignant. And what we look for is nuclear alteration in the size of shape of nuclei. So we call that nuclear pleomorphism of all the nuclei are different sizes and shapes. We look for the nuclear to cytoplasmic ratio. So if the nucleus is taking up the vast majority of the cell, that's an increase in the nuclear to cytoplasmic ratio. That's another worrying feature. Nuclear hyperchromasia. So if the nucleus is taking up lots of hematoxylin pigment, that's a worrying feature. Frequent mitotic figures, indicating that the cells are replicating uncontrollably. Lots of apoptosis, which is just a programmed cell death, which is happening, again, as a feature of the uncontrolled, unregulated replicating of cells. And if we see all of these things together as well as with the architectural features, we can put that together in a picture and come to the diagnosis of malignancy. That takes us so far in breast, but once you've diagnosed malignancy, that's not the whole picture, because there's two types within breast of malignancy that we're really concerned about. There's in situ malignancy and there's invasive malignancy. So in situ malignancy is when you get all these malignant cells. Imagine if this duct was filled with malignant cells, but they were still within the ductular structure. They still had the myoepithelial lining under which there is basement membrane. And so that's still containing the malignant cells. And that's malignancy in situ. The commonest type of malignancy in situ in breast is ductal carcinoma in situ, also known as DCIS. However, if we saw the same malignant cells, but they were invading every which way through the tissue, not contained with the duct, not contained within the myoepithelial lining or the basement membrane lining, that would be invasive malignancy. And the commonest cause of that within breast is invasive ductal carcinoma, NST. And that is analogous to other situations in different body systems. For example, in prostate, you get prostatic intraepithelial neoplasia, where it's in situ, and you get invasive prostate cancer. Within, probably the most common example is within the colon, where you can get adenomas, which can have high-grade dysplasia. An adenoma with high-grade dysplasia is still bound by basement membrane, so it's still in situ. But if you leave it long enough, the worry is that it will develop the invasive ability, get through the basement membrane, and then we call it invasive adenocarcinoma or colon cancer. And there are other examples in other areas of the body too. So that pretty much covers the basics of breast histology. I think we're going to move on next to lung histology. So hopefully you can join me for that. So speak to you soon.